Good morning. Good morning. This is Dr. Hall. We're doing another video. Today we're talking about how to differentiate between acute kidney injury and chronic kidney disease, and what are the initial steps for managing acute kidney injury in primary care. This is an absolute great question that I get a lot from our nurse practitioners, our physician assistants, and other medical doctors. I am a nephrologist, and I've been practicing for about 20 years, and we're basically trying to help you, the primary provider, bridge the gap between medical knowledge and clinical knowledge. We want you to be able to quickly make assessments of your patients, quickly determine what's going on with their kidneys, and put them on the right medications. There's a huge gap between what you learn in school, the basic medical knowledge and background, and how to actually apply that to a patient, to a clinical situation. So that's what we're going to do. We're going to try to help you do that. Check out our webinar below. We'll discuss some more cases. Today we'll talk about acute kidney injury and CKD, how to know the difference. You know, the biggest thing that you want to look at when you're trying to tell if a person has an acute drop in the renal function, or is this a subtle decline over time, you want to look at old labs. That's the best way to try to see if, is this 1 month, is this 1 week, 1 month, 6 months, or 1 year of drop or decline in renal function. That's very critical and very important to you as a provider, knowing, not only how acute this is, but also that curve gives you an idea of when that patient's kidneys are going to drop off the wagon, when they're going to stop working and be below 15%, and you got to be on dialysis. That's prognostically helpful to tell a patient, hey, you may be on dialysis in 3 years, in 2 years, in 6 months. Patients can kind of get themselves together, job, etc., etc. So just knowing that little curve and that graph of that GFR decline is helpful. I always look at old labs. When patients get referred in to me, sometimes they come in with no labs, and that's a little bit disheartening because I want to be able to check labs so that I can see what was going on a year ago, because it is important what's going on right now. What was going on 3 months ago? If their renal function was normal 3 months ago and it's 50% less now, something has happened in the interim that you as a provider have to investigate. Give you an example. I had a guy who was a coach. He was a weight training coach at a high school, and he was in his 50s, mid 50s. He was in really good shape. He worked out with the kids, and his renal function started to drop. And I went back and looked at his GFR, and his GFRs were like 30 to 35 to 40, over the last several years. They were pretty good. They were high enough that nobody really recognized that this patient's having some renal dysfunction. By the time I saw him, his renal function was pretty low. It was around 20 milliliters per minute. And so I'm trying to figure out why this 55-year-old black man who has hypertension, well controlled, why his renal function is dropping so fast. So, if I did not have those old labs, I could have just assumed he just had regular old run-of-the-mill kidney disease from hypertension, since it is the second most common cause of hypertension. But I didn't do that. I decided to actually look at his old labs, compare them to the current labs. We also checked the urine protein, urine creatinine ratio. They were somewhat elevated. And so, because this patient had undiagnosed acute kidney injury, we decided to do a kidney biopsy. This patient actually had allergic interstitial nephritis from ibuprofen. He had been working out a lot, trying to stay young, trying to stay healthy. He's a coach. He was a strength training coach, and he had developed an allergic reaction to NSAIDs. Acute interstitial nephritis is kind of like an allergic reaction in your kidneys to NSAIDs. And this is what this patient had. So just having the old labs and knowing that there was an acute drop in renal function over a 3 to 6 month period helped me kind of quickly, expeditiously move to managing this patient. We end up putting them on prednisone to try to reverse some of this acute interstitial nephritis. We obviously stopped the ibuprofen, and his renal function stabilized somewhat. However, over the next year or two, he ended up having to require dialysis because his renal function had suffered pretty significantly from the ibuprofen, aging, and hypertension. So, this was a case that, if I could have gotten this patient in a lot sooner, I would have warned him about the NSAID therapy. I would have told him that if your GFR is below 30, you should not take any NSAIDs at all. If your GFR is above 30, you should take them very cautiously. If it's above 60, you're probably okay taking NSAIDs. Just don't overdo it. And everything should be taken with a grain of salt with your NSAIDs, because anybody can be affected. Anybody can have an acute drop in their renal function, because they do have a predictable drop in renal function due to afferent arterial vasoconstriction. That causes a decrease in your renal blood flow, which decreases your GFR. So NSAIDs are a bad dude. That's a big question I ask when patients come in with renal disease. Have you been taking in naproxen, ibuprofen, BC powder, Toradol, indomethacin, diclofenac, meloxicam, Mobic? You got to kind of go down that list, because patients don't know what NSAIDs mean. They're not medical people. So you as a provider have to be able to communicate in the language that your patients understand. Don't communicate in the language that you understand, okay? I understand medical knowledge. You understand medical terms. Patients have no clue what NSAIDs are, the average patient in rural USA. So talk in terms that they can understand, and if there's a medication, I always use both terms, Mobic or meloxicam, naproxen, naproxen, Advil, Aleve, so you got to ask them different, you ask them the same question in a different way. This will help you as a provider get to the bottom of what's causing their renal failure. Other things that you can do to differentiate between acute kidney injury and CKD, you can look at their serum bicarbonate level. On your chemistry panel, it says CO2. Well, your serum CO2 levels are a surrogate marker for serum bicarbonate. That's why it says CO2. It's not the partial pressure of CO2 like in a blood gas. A blood gas detects the partial pressure in millimeters of mercury of CO2 and oxygen, but on your serum chemistry level, that's a concentration of CO2 actually in the blood, and it's a surrogate marker of the bicarbonate concentration. And so if your bicarbonate levels are low, that's an indication that this patient could have chronic kidney disease long-standing, because it takes a while for that process to take place. And so if you have metabolic acidosis, that's something that's been occurring over time. If your renal function drops quickly, you don't get metabolic acidosis overnight. Now, if you do have metabolic acidosis and a drop in renal function that's pretty severe or significant, you should think methanol poisoning, ethylene glycol poisoning, or even aspirin poisoning, or something acute that would drop your serum bicarbonate levels. And looking at an old serum bicarbonate is always helpful to help you decide, is this something acute or is this long-standing? Another thing you can do, you can look at the patient's parathyroid hormone levels. If their PTH is elevated, that indicates this patient has been vitamin D deficient for a while, and their calcium levels have been somewhat low. Serum calcium levels have been low. So the parathyroid hormones see that hypocalcemia, and they start to putting out parathyroid hormone to try to increase the amount of calcium reabsorption in the gut so that we can normalize calcium levels. So your parathyroid hormone, if it's high, that could indicate this patient has underlying chronic kidney disease. If the patient's renal ultrasound shows small kidneys, that's an indication that these kidneys are atrophying. They're getting smaller, which means that this patient has underlying chronic kidney disease. This is not an acute phenomenon. Another thing that you can see, if your patient has hyperkalemia and it was normal a week ago and they come in today and it's high, that's an acute rise in potassium. That's probably more of an acute situation. Patients like that, I look for things like Bactrim, things like aldactone or eplerenone, or medication that could potentially cause an acute rise in their potassium level, an acute rise in their serum creatinine level. I always ask about medications because medications can drop your renal function fairly quickly, and they can cause just all kind of electrolyte abnormalities. So always ask about antibiotics and be specific. Ask about, don't say, are you taking antibiotics? Ask them, are you taking Bactrim? Are you taking trimethoprim sulfamethoxazole, which is the same as Bactrim, or Ciptra? Patients don't know all these names, but you got to get specific and ask them what they're taking. You'd be surprised at how many patients have been sent to my clinic for hyperkalemia and they were taking Bactrim and that was the cause. Or for hyperkalemia and they were taking potassium supplements. Or for hyperkalemia and they were taking aldactone and that was the culprit. So always ask about medications and when they initiated these medications. Because that's so important, because lisinopril, the ACE inhibitors and R-type drugs can acutely drop your renal function because they cause efferent arterial vasodilation, which lowers your renal blood flow and it lowers your GFR. And a lot of the things that we do as providers cause a lot of problems in our patients. So remember that. Ask about, well, when you start this medication, when did you start this new blood pressure pill? When did you start this aldactone, this eplerenone, this lisinopril, this valsartan? All these medications are medical trials that we're doing in our patients when we start them. So you as a provider have to be able to quickly identify these types of things in clinic so you'll know this is an acute or a chronic issue. Other things that you can do, you can ask about, how long have you been diabetic? How long have you been hypertensive? Diabetes usually takes about 10 to 15 years for you to start seeing significant drop in renal function. If it's uncontrolled, that process is a lot faster. Hypertension, same thing. So, you can kind of, if you ask the right questions, you can get to the right answer. So those are the things that I do. The next video, I'm going to talk about initial steps for managing acute kidney injury. I'm going to stop this video because it's getting kind of long. But check us out. Check our webinar out. It's a free webinar. Check out our online course that we've offered that will talk about a lot of these cases and how to manage chronic kidney disease in clinic. And this will be a great resource for you as you improve what you do in your CKD clinic. We challenge you to read and see patients. If you want to get good at medicine, that's how you do it. You got to read and you got to see patients. Thank you. Goodbye.